This meeting is being recorded.
Good afternoon, ladies and gentlemen. A very warm and hearty welcome to this JMitra scientific webinar entitled Enteric Fever Diagnostic Challenges. We're very pleased to have with us today Dr.AgnijeetPalit from Lucknow. Dr. Palit is no stranger to the webinar scene or to the fact of to the sector of microbiology. He is currently the consultant at the Department of Microbiology at the Apollo Hospitals in Lucknow. Having over 15 years of experience in the medical field, Dr. Palit has published several papers and completed his MD from the Maulana Azad Medical College, New Delhi. He is a subject expert on the field of typhoid. And I would like to draw your attention to the fact that typhoid is one of the oldest known diseases, but it's also one of the severely under-recognized ones. It exists throughout the year, and given the state of hygiene of water in this country, it is endemic across most parts of the country. We estimate that there are over 4.5 lakh cases of typhoid positivity across 4.5 crores of typhoid positivity across the country today. And that is a serious cause of concern in the health sector, especially in the public health sector. We are here today with Dr. Palit, who seeks to draw attention to the severe challenges which affect us as we seek to diagnose enteric fever. Dr. Palit, with that introduction, I would hand over the forum to you and request you to take this session on enteric fever diagnostic challenges forward. Over to you, sir.
Thanks a lot. Very good afternoon to all my esteemed colleagues, my seniors, my teachers. So today's topic of discussion will be enteric fever diagnostic challenges. So the main crux of this topic will be the various challenges which we as doctors face while diagnosing enteric fever. As we all know that it is hyperendemic in our country and our adjoining countries, especially in the subcontinent. But there are several challenges in diagnosing this disease, especially due to its hyperendemicity. So first, what is enteric fever? So enteric fever is actually by definition a potentially fatal multisystem illness caused by Salmonella typhi, also known as typhoid fever, and Salmonella paratyphi A, B, and C, also known as paratyphoid fever. In India, Salmonella paratyphi C is not found. It's only Salmonella typhi and paratyphi A, B who are responsible for causing enteric fever. If we see the global distribution, we find that India falls into the category of high risk. There are other countries also, like the other subcontinent countries, the continental Africa, who are in the high risk. Countries such as Australia, the major part of USA and Canada falls in the low risk category. Current estimates from the WHO suggest that worldwide incidence of typhoid fever, enteric fever is approximately 16 million cases, and you will be surprised to know that it is responsible for greater than 6 lakh deaths, especially in the developing countries. To start with, I will be speaking a bit about the classification and nomenclature of Salmonella. We all know that Salmonella is a gram-negative bacteria and it belongs to the broader family of Enterobacteriaceae. Now, why the name Salmonella? The credit for discovery of Salmonella goes to Salmon and Smith, who discovered it in the year 1885. Salmonella typhi was first observed by Ebert and Gaffke, and hence this was formerly known as Eberth-Gafke bacillus or Eberthella typhi. Speaking about the antigenic structure, it is antigenically complex, and the classification and nomenclature has undergone several modifications. So basically there are few main ways by which we classify. First is the clinical classification, which is very straightforward. One is typhoidal salmonella, which includes Salmonella typhi and paratyphi. They are mainly restricted to human hosts in whom they cause enteric fever. And the other group is non-typhoidal salmonella, or NTS in the short form, which colonize the intestine of a broad range of animals, including mammals, reptiles, birds, and insects. They also sometimes infect humans, but they mostly cause foodborne gastroenteritis and septicemia. Next is the antigenic classification based on something known as Kaufman-White scheme. This is classified on the basis of the somatic O and the flagellar H antigens. However, nowadays, the classification is mostly based on the molecular hybridization studies, which have found that Salmonella basically consists of only two species. One is Enterica and one is Bongori. And within the species Enterica, there are 6 subspecies, of which one is again Enterica. There is Addisoni, Diaddisoni, Houteni, Indica, Salami. Now, each of these subspecies is further differentiated into the serotypes, as I have discussed earlier, based on the Kaufman-White scheme. And most of the pathogenic typhoidal and the NTS are placed under species Enterica and subspecies Enterica. So earlier, when we used to speak about Salmonella typhi, we used to write Salmonella followed by typhi, T in a small letter. But now this has changed. Now the actual naming of Salmonella typhi, if we write, should be Salmonella enterica, subspecies Enterica, serovar or serotype typhi. If we don't want to write such a big name, we only write Salmonella typhi, but T with a T is a capital. So Salmonella typhi, T is capital. This is again the Kaufman-White classification. As you can see, they are classified into serogroups. Serogroups earlier used to be denoted by the alphabets A, B, C, and D, but now they are denoted by numbers. And within each serogroup, there are multiple serotypes based on the H antigen. So the serogroup are based on the O antigen, serotype are based on the H antigen. If we see this antigenic structure, as I have said, they have a somatic antigen O, a flagellar antigen H, and a surface envelope antigen, which is found in some species, including Salmonella typhi. So difference between the somatic O antigen and flagellar H antigen is that somatic O antigen is a part of the cell wall, the LPS, lipopolysaccharide of gram-negative bacteria, which we know they are responsible for causing all the types of problems. The flagellar antigen is mainly made of the flagellin protein, which confers motility to the bacteria. In Widal test, about which we will be discussing a couple of slides after, we use the O antigen of Salmonella typhi and H antigens of paratyphi AB and Salmonella typhi. It must be noted that O antigen is less immunogenic than H antigen. It appears early and disappears early, hence it indicates recent infection. Serogrouping of Salmonella is based on the O antigen, as I have said, and then serogroups are differentiated into serotypes based on the H antigen. VI antigen, which is present in some species including Salmonella typhi, paratyphi C, and Dublin, they are also found in some strains of Citrobacter frundi. It is poorly immunogenic and antibody titers are low, hence it is not employed in the Widal test. But it is believed that the complete absence of the VI antibody in a proven case of typhoid fever will indicate poor prognosis. The VI antibody usually disappears in the convalescent phase early, but if it persists, it indicates the development of the carrier state. That is why the detection of VI antibody is used as a tool for detecting carriers for typhoid. It is also used in fast typing of Salmonella typhi by specific bacteriophages, and it is used also to prepare vaccines. Now, shortly, if we see the pathogenesis of enteric fever, it is mostly transmitted through fecal-oral route, and that is why in a country like India, where the level of hygiene and sanitation is quite low, especially in the rural areas and also in the urban slums, this disease is very hyperendemic in this country. The infective dose of Salmonella is 10 to the power of 3 to 10 to the power of 6 bacilli, slightly higher than Shigella. It enters through the epithelial cells of the M cells lining the intestinal mucosa. They are usually imported into the cell by what is known as bacteria-mediated endocytosis, and this is mainly mediated by the type 3 secretion system of the cell. Following entry, the bacilli usually remains within the vacuoles. From the vacuole, Salmonella containing vacuoles, they cross the epithelial layer to the submucosa where they are phagocytosed by the macrophages. However, contrary to the other infections where the macrophages are able to kill the insulting microorganisms, Salmonella typhi induces certain alterations on the surface of its lipopolysaccharides so that it is no longer susceptible to the lysosomal enzyme. That is how it survives within the macrophages. Salmonella contained inside the macrophages then spread by the lymphatic system into the bloodstream, causing what is known as a transient primary bacteremia, and from there they disseminate throughout the reticuloendothelial tissues like liver, spleen, lymph nodes, bone marrow, and other organs like gallbladder, kidney, lungs, where further multiplication takes place. And secondary bacteremia actually occurs from these seeded organs, which leads to the onset of clinical disease. Incubation period is 10 to 14 days. Although it is enteric fever, means related to the GI tract, but the manifestations are mainly extraintestinal. The most common and classical is step ladder pattern of remittent fever. That is, the fever usually follows a step ladder pattern. It rises gradually to a higher level, then falls down, but does not touch the baseline. So if we see the temperature charting of a patient with typhoid fever, this is the classical picture which we get. There are also other symptoms like chills, cough, sweating. There are rashes which are known as rose spots, which are mainly salmon colored blanching maculopapular rashes on the trunk, seen in 30% patients at the end of first week. However, they will only be seen in a fair skinned individuals. There are early intestinal manifestations like abdominal pain, nausea, vomiting, and there are other signs like hepatosplenomegaly, relative bradycardia. Complications, yes, if it is not treated, if it is not diagnosed, then it can lead to various complications, of which intestinal perforations, GI bleeding are the most common in the 3rd and 4th week of illness. Neurologic manifestations, although they have reduced quite drastically nowadays with better availability of treatment, but there are symptoms like cerebellar ataxia, neuropsychiatric symptoms like delirium, which we also known as coma vigil. Now coming to the carrier state. So typhoid has a unique this distinction of causing a long-term carrier state. How it happens? The untreated patients become carriers who remain fairly asymptomatic, but they are carriers of the bacteria and they continue to excrete this bacteria in the feces or urine. There are mainly two types of carriers, fecal and urinary. Urinary carriers are rare, whereas fecal carriers are more common. In fecal carriers, usually they multiply in the gallbladder and are excreted in the feces. If we speak about the duration of shedding, there are temporary carriers in which this can occur up to 3 months, and in chronic carriers, they excrete the bacteria in urine or stool for greater than 1 year, which is seen in 2 to 5% of patients. I must also tell you that there's this famous incident of a person who has been known as Typhoid Mary, who was a New York cook and was a chronic carrier, and who gave rise to more than 1300, that is 1300 cases during her lifetime, and caused several outbreaks. If we speak about the laboratory diagnosis, this is the most important part. So laboratory diagnosis will depend on the period of the illness, the specific window of the illness. So first week of illness, blood culture or bone marrow or duodenal aspirate culture is the most important diagnostic tool. Serum specimen for serology mostly in the 2nd or 3rd week of illness, and 3rd or 4th week of illness, so urine and stool culture. Speaking about culture, so the most common test which is prescribed during the first week of illness is blood culture. Here I want to reiterate certain points. Blood culture is considered to be the gold standard for diagnosis of typhoid fever. It even at this age. But the problem with blood culture is that the specimen needs to be collected properly. First, at least 10 ml of blood per blood culture bottle needs to be collected. Next, you have to collect the blood culture specimen before the starting of antibiotics. So it is seen that if we follow these parameters, the blood culture isolation rate is quite high. Bone marrow aspirate culture we do if blood culture is negative and there's a high degree of clinical suspicion, and duodenal aspirate culture if blood and bone marrow culture are negative. Stool and urine culture we mainly do in the 3rd or 4th week of the disease, and also for the detection of carriers. So from the culture, what type of colonies we can expect? So in McConkey agar, which is a poorly selective medium, we will have non-lactose fermenting pale colonies. If we use selecting medium like BC or deoxycholate citrate agar, we will have pale colonies with jet black center. If we use XLD agar, we will have red colonies with jet black center. There are also other media like Wilson Blair brilliant green bismuth sulfide medium, in which they will produce jet black colored colonies. So these are the various media which we can use for culture, and identification we can we can use manually with the help of biochemical test. We all know that it is catalase positive and oxidase negative, indole citrate and urease negative. And if you see the triple sugar iron agar, it will have a K by A or the alkaline by acid, and gas will be present except for Salmonella typhi, which is anaerogenic. Abundant hydrogen sulfide production is seen in Salmonella paratyphi B, but not in Salmonella paratyphi A, and in Salmonella typhi there is only a speck of H2S. We can use automatic systems like Vitek 2 or Multitoph, but it must be noted that Multitoph only detects up to genus level, because the similarity in ribosomal proteins among the various groups of Salmonella, various serotypes of Salmonella. We can also use the slide agglutination test for Salmonella typhi. It agglutinates with O9, for paratyphi A O2, and Salmonella paratyphi B with O4. This is on the basis of the Kaufman-White classification, and thereafter we proceed for the antibiotic susceptibility testing, which is done by distribution method or MIC with the help of Vitek 2 compact. Now comes an important and very useful test, but not properly interpreted in most settings. That is the Widal test. Now, Widal test is quite old. It has been used from a very long time. It is basically used to detect the presence of serum antibodies against the Salmonella typhi and paratyphi bacteria. So in this test, that is in Widal test, what we do is that 4 antigens are used: O antigens of Salmonella typhi, H antigens of Salmonella typhi, and H antigens of Salmonella paratyphi A and B. We are not using the O antigens of paratyphi A and B because they have a sharing of the factor 12. That is why they cross react. So what we do is that we serially dilute patient serum in normal saline in test tubes from 1:10 to 1:640 dilution, and 4 such sets are made, and to each set of diluted sera respective 4 antigen suspensions, that is TO, TH, AH, BH, are added, and these tubes are incubated at 37 degrees centigrade overnight. Felix tubes for O and Dryas tube for H. It also must be noted that this is the mechanism of the tube Widal test. There are also slide Widal tests available, in which we don't need to incubate overnight. If we speak about the results, the O agglutination appears as compact granular chalky clumps with clear supernatant fluid, and the H agglutination appears as large loose fluffy cotton-woolly clumps with clear supernatant fluid. However, if agglutination does not occur, button formation will occur due to the deposition of antigens, and the supernatant fluid remains hazy. How we know about the titer? The highest dilution of sera at which the agglutination occurs is taken as the antibody titer. So here we can see the picture. This is a picture of the slide Widal. This is the rapid Widal, as we know. These are the various tubes. We can see the agglutinations happening, and this is the O antigen This is the H and this is the O antigen tube, H antigen tube. So here in case of the O antigen, as we see, the agglutination forms chalky clumps, and in case of the H antigen, it forms the cottonwoolly fluffy clumps like cotton wool, and this is read with the help of this concave mirror. Here we can see. Now it must be noted that any titer in Vidal is not significant. This is due to the fact that India is a hyperendemic country. So we need to know what is the significant titer. So in significant titer, although it varies from place to place, and we also known as local titer. So in order to interpret a Vidal test, we need to know the local titer of that region. But mostly we can say that H titer of more than 200 and O titer of more than 100 should be considered as positive. So it's very clear that if TO and TH antibody both rise, it indicates salmonella typhi. TO and AH is paratyphi A, TO and BH is paratyphi B. In recent infections, there might be rise of only TO antibody, and in TH antibody might be present in the convalescent stage or an anamnestic response, which I will be speaking about now. Rise of all the antibodies might be seen after TAB, that is typhoid vaccination. So coming to the limitations of Vidal test. Now first is anamnestic response. That is a transient rise of titer due to unrelated infections in persons who have had prior enteric fever. So suppose a person has had enteric fever in the past, he gets malaria or dengue or other infections, not enteric fever, but malaria, dengue, other infections, there will be a transient rise in titer. If bacterial antigen suspensions are not free from fimbriae, the antigen suspensions which we use are free from fimbriae, that is in non-flagellated. If they are not free from fimbriae, then also the false positive result might occur. Again, persons with inapparent infection or person with prior immunization. Here I must want to reiterate the fact that the problem with Vidal, or the basic drawback of Vidal, if you say, is that a single Vidal positivity is not significant. You have to demonstrate a fourfold rise in antibody titer at a gap of around 10 days to 14 days. That is the most classical way of diagnosing it through serology. But usually what we do is that either we take a very low titer as a positive case, or what we do is that we don't do a repeat testing, because if we do a repeat testing and demonstrate a rise in titer, that in most cases seals the diagnosis. So here the fourfold rise in antibody titer demonstrated by testing paired sera at 1 week interval is more meaningful than a single high titer. And rise in titers due to anamnestic responses, as I have said earlier, it usually falls after 1 week, whereas in true infection the titer increases after 1 week. That is why this gap between two tests are required. This should be kept in mind because this is seldomly followed. I myself, as a doctor in my career, I have rarely seen doctors prescribing two Vidal tests at a gap of about more than 1 week. Again, false negative Vidal might occur because in early stage the antibodies are not formed. Late stage, after 4th week, carriers, patients on antibiotic, and also Prozon phenomenon like in any other serology tests. O agglutinins appear early, disappear early, and indicate recent infection. H agglutinins appear late and disappear late. Now coming to the other antibody detection tests. So first is Typhi test, popularly used, widely used. So what is that? It usually use a lateral flow assay, or RIT, or a ELISA based test. The 50 kilodalton outer membrane protein antigen is used to detect both IgM and IgG after 2 to 3 days of infection. There are several brands commercially available, one by Anand Brothers, by JMitra. There is also ideal Tubex test in which O9 antigen is used, detects only IgM antibodies by a semi-quantitative colorimetric method. There is a IgM dipstick and ELISA available to detect anti-LPS IgM antibodies, and there are dot blot assay where flagellar antigen is used, which detects only IgG antibodies. Speaking a bit about the Typhi lateral flow assay, like in all RITs, it uses anti-human IgM antibody and anti-human IgG antibody, IgM and IgG respectively, from the test line M and G, which is immobilized on a nitrocellulose strip, and conjugate is there which contains colloidal gold conjugated to S-typhi antigen, which is prepared from culture. Now when a specimen is added by followed by the assay buffer, S-typhi specific IgM and IgG antibodies, if they are present, will bind to the S-typhi antigen gold conjugate and they will make a complex. This complex will then migrate through the nitrocellulose membrane by capillary action. And like in other varieties, when this meets the line of the immobilized monoclonal antibodies, it is trapped, forming a purplish pink band which confirm a reactive test result. There are other tests like to detect the serum antigens. Antigens of typhoid or salmonella are present in blood in the early course of the disease and also in the urine of patients in the late phase. So to detect it, several methods such as ELISA are available, but these are not much popular. We are also having PCR nowadays, and the targets which are used are mainly the flagellin gene, IROB, and FLIC gene. We have TrueNat in our hospital, so we have TrueNat by which we can test for the PCR for salmonella. Carrier detection, again, it is important as a part of the control process. One is by stool and bile culture and urine culture, and then is detection of VI antibodies. But VI antibodies, we use what are known as Bhatnagar strains, that is Salmonella typhi suspension carrying VI antigen, and here a titer of 1:10 is also confirmed significant. Isolation of Salmonella from sewage, because Salmonella can persist for a very long time in sewage waters. It can be done by sewer swab technique and filtration. Coming to the prophylaxis part, in prophylaxis mainly we are doing mainly three things: control of reservoirs, which includes treatment of cases, and control of carriers. Control of carriers we do by giving them amoxicillin and probenecid for 6 weeks. We try to improve sanitation, and there is obviously vaccination nowadays. It's a common practice that we immunize children with the help of typhoid vaccine. All these things taken together will probably help reduce the incidences of enteric fever in India. Treatment, earlier we used ampicillin, chloramphenicol, cotrimoxazole, but now MDR strains are there. Ceftriaxone being the drug of choice. Alternatives are azithromycin. Fluoroquinolone's resistance is again rising, so it is rarely used nowadays here. So speaking about the review of literature, because there are a lot of things to be discussed regarding these various tests. So one thing should be kept in mind that blood culture and PCR still remains the gold standard. Serology tests have varying sensitivity and specificity. Vidal has its own advantages and disadvantages. So just take a look at the different studies which has been performed in other countries and in and around our country in the subcontinent. So our systematic review and meta-analysis for the performance of 2 point-of-care typhoid fever tests like the Tubax and the Typhidot in endemic countries was done. This was a study from the Belgium. They did not find good sensitivity and specificity for the use of RDTs for the diagnosis and treatment. Then there was a study from Karachi in Pakistan in which they studied 145 febrile patients. The 15 had positive blood culture for Salmonella typhi, 7 had for Salmonella paratyphi, and 94 had positive culture for other organisms. So here it was found that among the 15 patients with typhoid, 11 showed a negative typhidot result. The sensitivity was 26.7 and the specificity was 61.5. And they concluded that even though typhidot is rapid, its use should be discouraged due to low sensitivity. But there are studies which have found relatively good sensitivities. So if we see, this was a study from our country in Aligarh. They had compared again the typhidot-M and Vidal test. So it was found that the relative sensitivities in the first week of illness was typhidot 86.2%, 41.4% for Vidal. So it was found to be more sensitive than Vidal. Then again, a study from South India, Mysore. There was a comparative study between typhidot-M and Vidal test. So sensitivity and specificity was 92.6% and 37.5%, whereas for Vidal it was 34.1 and 42.8. So they conclude that typhidot-M is a simple and sensitive test for the early diagnosis of typhoid fever. Again, a study from a neighboring country, they found that for the Vidal and typhidot test, 63 Vidal and typhidot was 63 and 83% were the sensitivity for Vidal, and 85 and 95% for the 97% for the typhidot. So they concluded that the .EIA, or the enzyme immunoassay typhidot, is a more sensitive and specific test which is easy to perform and more reliable compared to the Vidal test. So again, a study from CMC Vellore, again they found that what they did was that the typhoid test they found was positive for both IgG and IgM in 39 samples, IgM in alone in 24 and IgG in 2. And of the 30 culture positive sample, 27 were positive by typhoid. So the sensitivity was 100% and specificity of 80% was obtained. And they also concluded that it is a easy to perform test and it can be used as a test which is complementary to the blood culture and Vidal test for the diagnosis of typhoid fever. Another study from Bangladesh where they compared 3 rapid diagnostic tests. So for the different tests for the different rapid RITs, they found of different companies there were varying sensitivity and specificity of 59%, 61, 59, 74, 24 and 96%. Another study from Karnataka, India, what they did was that they did using blood culture as the gold standard. They found that typhoid showed a higher sensitivity compared to the Vidal test, and specificity of both Vidal and typhoid remained the same. So if we see the varying diagnostic techniques, again I said that molecular identification with the help of PCR, blood culture provided it is done properly. Mostly in the first week the blood sample is collected properly, it is collected before the administration of antibiotics. Blood culture still remains the gold standard along with PCR. Serological tests have their own merits and demerits, but they are a very useful tool because obtaining blood culture correctly is not possible all the time, and most of the patients come after the administration of antibiotics. So what to do is that we can use Vidal test, we can use typhoid test, but they should not be used solely as a diagnostic tool for the disease. They have to be interpreted with caution. If we use Vidal test, we have to keep in mind that it is better if we demonstrate a 4-fold rise in antibody titer. We have to keep in mind the local titer also. If we use the RDTs or the typhoid tests, again they have advantage that if we quote the various studies in the first week of illness, obviously Vidal is not a preferred test, but in the first week of illness, typhoid has a greater sensitivity as compared to Vidal test. But then it has to be corroborated with the clinical findings of the patient, and we will always have to have a high degree of clinical suspicion. So diagnosis of enteric fever should be made considering clinical findings as well as laboratory test results. RDTs or a single Vidal value should not be the only criteria, and all diagnostic tests must have their limitations. So this should be kept in mind while interpreting the test results. So these are the things which we should keep in mind. And typhoid fever, yes, it poses challenges in diagnosing, especially in a country like India. But what we need to do is that we have to compare the test result with the clinical findings of the patient, not rely on a single test. We have to use a battery of tests. Then only we will be able to correctly identify all the cases. So thanks a lot. Thank you.
Thank you very much, Dr. Palit. That was indeed a very, I would call it a, can I request you to switch on your video, sir?
Yes.
You know.
One second, please.
That was indeed a very, I would say, a very balanced presentation, sir. Because, given the fact that the Indian subcontinent is an extremely endemic when it comes to the typhoid, incidence of typhoid, how does one establish a baseline? Because I believe that when the Vidal test is done, sometimes if you're doing it for the first time on somebody who's infected for the first time, yes, it's rather accurate. But when somebody has repeated exposure to typhoid, then establishing a baseline titer becomes a very big challenge. And then the Vidal test, even though it is the oldest test, apart from the culture, it's one of the oldest tests, more than 100 years of history behind it.
Yes.
Served us well, but it seems to come up short at some point, right?
Yes, yes, yes. Especially in persons with repeated exposure. So what we need to do is that first we need to know the local titer of that region, and after that local titer, there's a process for calculating the local titer. We take samples from clinically febrile patients. Then we find out the mean titer, and that is how we establish the local titer. And for patients with repeated exposure, again, a single Vidal test is not at all accurate. The repeating of the test at an interval of more than 1 week is very important. So we should not go by a single Vidal test result. We have to repeat it after say more than 7 days, and we have to demonstrate a rise in antibody titer. Even with a person with repeated exposure, a rise in titer will always occur with a new exposure to the bacteria. So that is how we can diagnose this disease. But then again, culture and molecular methods are gold standard, but molecular methods, again, it also has its demerit, because it will be positive only during the phase of bacteremia. If
Absolutely.
the bacteremia phase has passed, the PCR will be negative. Again, PCR will be negative. So we have to use a battery of tests. We have to have a high degree of clinical suspicion. Then only we can diagnose typhoid fever, and we'll also have to see that the typhi test, like the Vidal test, can also have a false positive and false negative aspect also. So all these things we have to keep in mind. But in my honest opinion, what I have seen is that in cases of enteric fever, we have compared both the tests. We have found a higher sensitivity for typhi, because there are false positives. We have found false positives, but then in all the cases in which the blood culture was positive by the 7 days or more than 7 days, we could demonstrate a positive typhi.IgM. So that's what I'm trying to say, is that the sensitivity we found to be good, but there are cases highly sensitive test will always have false positives. We have to keep this in mind. But then we need to have a high suspicion, and we need to do other tests also. So it will be a collective diagnosis, not based on a single test.
Absolutely, sir. Something I learned from the COVID pandemic was that there has to be a proper established testing algorithm. Something
Yes.
that has been put in place, as a public health policy, the government of India has put in a proper testing algorithm when it comes to the COVID test. You have a test number 1, test number 2, and a proper algorithm saying, if not, then else, what else, I
Mhm.
don't think that is established in typhoid. Maybe typhoid came too early in the system, so nobody took it as seriously as they should. Because when you said that doctors should prescribe 2 Vidal tests 7 days apart, your own statements here, if I may recollect back to your own statements, was that not too many medical professionals actually do that. The question
Yes.
is, do the patients have those 7 days?
Yes.
It impedes the treatment profile, and 7 days delay in establishing what is the cause, in fact, in establishing a correct diagnosis, can prove detrimental to the treatment plan or the patient's health, sir.
Yes, yes, yes. So, in my honest opinion, what I feel is that you do a baseline Vidal test. If you are suspecting enteric fever, if the single Vidal test comes as positive, you start treatment, and then you repeat a Vidal, because the titer rising is not that much affected by the administration of antibiotics. Once you do a Vidal test, you then start antibiotics, then repeat the test. Okay, there's no harm in, because you have to treat the patient. You just can't say that, okay, I will treat you after, say, by that time he might be having neurological manifestations. So you have to treat the patient, but then to establish your diagnosis, you can repeat the test. And yes, there is no established testing algorithm for enteric fever, because mostly due to the fact that, one, if like there's COVID algorithm can be established, because in COVID, if you take the nasopharyngeal or oropharyngeal swabs, the presence of the virus is there throughout the course of the disease. But in typhoid, the problem is that if we see blood also, it is only there mainly in the first week of the early second week of illness, and thereafter after the bacteremia passes, we will not get it from blood. Similar for the PCR also. So it is very difficult to establish a algorithm. They only say that first week you do blood culture, second or third week you do serological test, and then third, fourth week onwards you do the stool or urine culture. That's what they say. But then again, there's not a very clear-cut guideline like in other diseases.
So thank you, sir, because I believe that, it is important given the fact that this disease is endemic in this country. It's not a vector-borne disease, as in not a mosquito-borne disease, or it is something that affects each and every one. Anybody who drinks water, and given the lower income strata of society that we have, the lower income strata is at a higher percentage of the Indian population. They are more vulnerable to it, and repeated what I call it exposure to this particular virus puts them at a severe disadvantage versus, let's say, a first world nation, right? And we're not heading for the graph will continuously go on an upward tangent then. Right? There's no seasonality to this, unlike vector-borne diseases. So we are facing a public health challenge of enormous proportions down the line, down the line. So, I mean, these webinars are not here to, we're not here to change public policy, but we are here to open people to the thought that, especially those of you in the medical profession who can raise a voice and bring it to the attention of the administration, that I'm sure that even at the Apollo Clinic in Lucknow, where you are presently stationed, you have your own little algorithm to do this testing for typhoid. And as per the public health intelligence reports of 2019, UP, Bihar, Jharkhand are pretty much the epicenters of typhoid incidents. Wherever you have a water, because most of the people live along the river Ganga, and the way it is that there is a lot of people consuming from that particular river. You're facing challenges. Do you have an algorithm in place? Is there something that you use personally, which you would recommend?
So what I recommend is that the clinical history of the patient is very important, the duration of fever. Because I have said that you have to look at all the aspects. So what I personally do is that if someone comes to me or someone consults me for a probable case of enteric fever, first I take that person's history, that for how long the fever is present, what is the pattern of the fever. I look at the CBC, because in typhoid it is very classical. There's a relative lymphocytosis in typhoid fever. So these things I take into account, and then obviously first I do blood culture. If the patient has not consumed antibiotics, and if blood culture is negative, we do a Vidal test, and obviously I always impose the fact that please repeat the Vidal test after a gap of more than 1 week to establish the diagnosis. Also, serological testing, blood culture is not possible if blood culture is negative or 1 week has passed. We also do TyphiIgM, that is routinely prescribed. But then in all positive TyphiIgM cases, I write that it is a probable case of enteric fever, but not a confirmed case of enteric fever. So that is the little catch in enteric fever. We cannot say for sure. It might be a false positive case also. So that is the algorithm which I suggest. You treat the patient, but then you don't stop looking for other diseases also. So initially, I was saying this, that it has to be diagnosed in unison with all the factors. So recently, there was a case in which patient had a TyphiIgM, had a history of fever of 4 to 5 days. The TyphiIgM came positive, and the doctor straight away started treatment for enteric fever, which was okay. That is not an issue. But the problem was that in such cases, you have to follow the patient up and look for other cases also. So post antibiotic therapy, the patient didn't improve, developed a pleural effusion, and on tapping the pleural fluid, it was found it has a very high ADA or adenosine deaminase level, which is an indicator of tuberculosis. Okay, so this chronic fever, this non-remittent fever, pyrexia of unknown origin, not only occurs due to typhoid. So you have to look for other cases also. Just on a single test result, you cannot sit back and say that, okay, this is enteric fever and I will do nothing. I will just give the antibiotic for enteric fever only. So that is what I'm saying. The follow-up of the patient is very important.
I agree with you completely, because antibiotics, while they are also a boon, they also serve as a curse in the long run. The resistance that builds up. and you have the antimicrobial stewardship and programs in most hospitals now.
Yes,
Because
yes.
of this particular thing where you jump, I don't say jumping the gun, but I say preventing a bigger loss by starting the treatment immediately. While
Yes.
the cross reactivity, especially even in the Vidal test, there's a lot of cross reactivity with non-salmonella tests.
Yes.
So you end up with a lot of doubtful cases. So I believe that the gold standard, of course, being the culture test, but again, that's not the easiest to administer, and it's only
Yes.
available for the
Yes.
first starting period bacterial cases when you have the
Yes.
antigen detection happening.
Yes.
So yes, this is an open question, I guess, and not one which is easily resolved. There are too many ifs and buts here.
Yes. That's right.
We had a question. We had a couple of questions from the attendees where I would request your attention. One was, what is the correlation between the OMP-based kits and the O&H-based kits? If you could shed some light on that, sir.
I couldn't get the. Please repeat.
What is the correlation between OMP, outer membrane protein-based
Outer membrane protein, yes,
and the O&H-based kits?
Okay. So what I have seen is that both are widely used as a diagnostic tool, but I did not find any greater differences between the two in my personal experiences. Both had a similar sensitivity and specificity. If we see, so in my case, that is in our hospital, both had given similar results with the almost same degree of false positivity in both the cases.
All right. Among the Vidal and the Typhi dot test, or let me call it the rapid test, right? We do understand that the various studies that you showed us today, that there is definitely a marked difference in the sensitivity of the two,
Yes.
marked sensitivity. Yet, it is now this is something I've observed, that still a lot of the medical practitioners opt for the Vidal test. Is it a comfort factor? Is it a resistance to change? What is your observation?
I would say that it is a resistance to change, because the thing is that or again, some comfort factor might also be there. If we see the different tests, the Vidal test is a more difficult test to perform. We have to put serum in serial dilutions, whereas these rapid tests are very easy to. They are point of care tests, so that instigates people to write these tests. But in my honest opinion, I feel that if the patient is in the first 4-5 days where there is a greater sensitivity of the Typhi dot test, so we can prescribe Typhi dot test within the first week of the illness. Even beyond that, we can prescribe. But then in the first week, if we see the studies, it has a much greater sensitivity than the Vidal test.
All right. Thank you so much, sir. And we appreciate your time and your effort. You really, like I said, given a very balanced opinion. And I think that's what the aim of these webinars is, to give a balanced opinion, right?
Yes.
We don't want to come to a conclusion here, right? Because, but it's good to have people come out with an open sense of understanding of the subject. And thank you so much for your time. We have a small certificate of appreciation for you. And of course, our team members in Lucknow will be in touch with you to deliver the final certificate, right?
Okay, thank you.
A quick question for you before we go from here is, there's a rise in COVID again, right?
Yes.
Is this just off the top thought? Is this something that you see as a mild manifestation, or do you see have we lost our edge? Have we loosened our grip on the subject so far that things might get out of hand again?
This is a very interesting question which you have asked. This is the question which many people are asking me. So the viruses are a very funny character. You see, we can't predict in which way they turn. Nothing can be said for sure, but there's a but. The fact is that in India, due to the first wave and the second wave, the deadly second wave, the level of antibodies and the vaccination coverage also, the level of antibodies at this point of time is more or less optimum, provided the virus does not undergo a very drastic mutation. We had spoken about the Omicron variant and the sub variant of Omicron, also the XBB variant. Look, in COVID, the entire game is dependent on the rate of hospitalization. The entire thing is dependent on the rate of hospitalization. If the rate of hospitalization remains the same, it falls, it does not rise much. Like what we are seeing now is that even today we got 2 COVID positive cases, but then they are just walk-in patients. They did not have very severe symptoms. So such cases which can be managed at home and there are not much hospitalizations happening due to COVID, we are okay. It will be treated as a normal upper respiratory illness. But again, if the virus undergoes a very drastic transformation, which no one can guarantee, no one on earth can give it in writing that this COVID virus will not undergo a drastic mutation. So if it undergoes a drastic mutation, then anything like second wave can happen. So what happened in second? It was a Delta variant. It was a deadly Delta variant which was responsible. Right. And people at that point of time, the population were naive to that Delta variant. So there was a huge, like there was a catastrophe. Yeah. So but then if you speak about the Omicron variant didn't cause much havoc because of the similarity of the antigenic structure. So the level of antibodies which were there, they more or less managed the situation. So till now we are keeping our fingers crossed. Till now there's nothing to worry because the rate of hospitalizations have not gone up and most of the patients are recovering like with the common cough, cold and with a sore throat and all these things. So till the time such things are continuing, we can be hopeful, but we are not sure that the virus will not do something drastic.
Well, that like unfortunately that is not in our hands or in our purview. Right? The virus has a mind of its own, right?
Yes.
Like any living organism. Yes. But thank you so much for your time, sir, and your effort. We had a great time and we look forward to working with you again on this. Thank you. Have a great day. Thank you everybody for joining us today. We will see you on the 27th of April for our next webinar entitled Wheat-Related Disorders and Autism. Thank you.